Welcome to this very special session or meeting of the IDMP program at the Broad Institute. These are extraordinary times, and so we felt that a special seminar was warranted to try to address some of the questions and the chaos that have been ensuing both in the United States and around the world because of the current coronavirus pandemic. We have invited a very special speaker today. And Jamie is very special to the community and actually to myself for many reasons. But for me personally, Jamie was my attending physician who taught me what little I know about infectious diseases. And he's really a leading clinician at the Brigham. But actually what he's going to talk about today is his experience in 2003. At the time, he was a branch leader at the CDC and was sent on behalf of the World Health Organization to work with a team that was sent to China to actually observe and interact with the Chinese and the Chinese government in their response to Sars. And so Jamie's going to talk a little bit about his experience. I've heard some of it, and it's fascinating, and I hope that all of you will be as fascinated. But also, I asked him to talk about lessons that we learned there that should help us try to think about and put into context what is going on even this very minute. So he's going to talk for a little bit, and then we're going to really open up the time so that he can take questions. I think you will all be submitting them online, and so we'll be receiving them here. We appreciate Jamie coming to speak to this standing room only crowd here in the auditorium, or the virtual crowd. So with that, Jamie, thank you so much for coming.
Great. Deb, thank you very, very much. And it's really great to be here and all the people out there. And Deb, you're wonderful. Deb, don't let Deb sell herself short. She is a phenomenal clinician as well as an amazing scientist, as we all know. So 17 years ago today, World Health Organization issued something it hadn't done before, a travel warning and an advisory. That was big news. Here in the US, we didn't hear much about this because if you remember back then, we were on the verge of going into Iraq. And so all the focus here was on Iraq, whereas the rest of the world were really focusing on SARS. And I think there's a lot of parallels between what happened then and what's happening now. And I think a lot of things we can learn, there are some important differences. So just to remind you about SARS. This was the SARS coronavirus. The outbreak started in November 2002, as far as we know, ended in July 2003. 8,000 cases, almost a 10% case mortality, 30 countries. China was where it started, and China was hit the heaviest with the greatest number of cases and deaths. Economic losses were astronomical, at least $40 billion. China's GDP went down several percent as they predicted and went through a lot of sacrifices. Some big differences between the COVID illness that we're seeing now and SARS. So the present one seems to be more contagious. And so I think transmission is much more widespread than what we saw during SARS. On the other hand, the disease with SARS was more serious. When people got sick, the mortality was greater. And I think these will explain some of the important differences in epidemiology that I think we want to keep in mind as we talk about this. So what was the WHO team? We were called the expert team. We were not experts. We had one virologist, a senior virologist from Australia. There were two epidemiologists, a pulmonologist, and I was the ID, infectious disease person. We were not experts. We were learning on the job. Getting into China back then, China had to invite WHO in. And so our terms of reference were to come and offer technical support to China to identify the chlamydia that was causing this strange pulmonary illness. And on electron micrographs of patients who died from what turned out to be SARS saw some inclusions that looked like elementary bodies. And this very famous virologist thought it was a chlamydia. So for several weeks into our work, the government kept asking us, well, we want to know about the chlamydia. We got to Beijing and met with the World Health Organization there and got their perspective of what they wanted us to do. They wanted us to get into Guangdong province in the south where it all started to find out what was going on, what was the status of the epidemic. Other teams hadn't been able to get in. And then to put pressure on the Chinese government to do a number of things, report number of cases on a daily basis, to join several global networks, epidemiology, laboratory, clinical, that met by phone every single night, and to be open about what was going on. And they said the way you're going to do this is with a series of press conferences. 3 times a week, we're going to have a formal press conference. And by the way, the first one starts in 15 minutes. We walked into this room, there's about 150 people all over the world. So New York Times was there, CNN, BBC, and all the Chinese news agents. It was very intimidating. But as the time went on, we ended up working very closely with our Chinese colleagues, the Ministry of Health, the China CDC, people in the provinces, in the local governments, hospitals, clinics, the whole level. There were 4 parts of the epidemic in China that I want to focus on because I think there's nice parallels to what's going on right now. So the first is where it started in Guangdong. And when things were fairly slow at the beginning, recognition and first responses. And then, and I don't think you see that too well here, but there's the outbreak in Guangzhou City, then the major outbreak in Beijing, and then finally what it took to wrap this thing up and bring it to an end. We're talking a lot today about, in the news, about containment versus mitigation. And this was an epidemic that was contained and interrupted. And that was the goal of the Chinese government. And I think when you listen to WHO and you listen to the Chinese, people are still talking about containment. And I think one of the discussions we might want to have is where do we stand now in terms of mitigation and containment? We'll come back and talk about that. So in terms of how it all started, the first reports came to the government in early January 2003. This unusual pneumonia. The health authorities went in and investigated. It took them several weeks, but they figured out this was a new disease. This was something they hadn't recognized before, which was a fairly amazing accomplishment. I think the other accomplishment was whoever picked up that something strange was going on in the midst of flu season. Some very sharp clinicians came to that conclusion. And I think the same happened in Wuhan this time. Who was it who first made the connection that this is not flu, this is something different? And is there a science to that we can get better at picking up new outbreaks? Investigation showed that the first case, actually that they could recognize, went back to the fall in November. The investigation identified this as a new disease, didn't know the etiology, didn't know where it was coming from, but had some ideas about how to take care of patients, how to prevent people from becoming infected, and issued instructions to all the provinces about how to deal with this. If you look at the cases early on, there were 7 different foci in which cases were popping up right at the beginning, and small clusters and very, very small numbers. And the Chinese government, in retrospect, was criticized for not bringing attention to the outbreak at this stage. But things were really very, very slow moving and low numbers, and not clear what all was going on. That changed. And at the end of January 2003 is when the epidemic exploded in Guangzhou City. And so literally hundreds of cases appearing all at once. The government was silent during this time, but word got out to the public, and there was panic in the public. People were communicating by cell phones, sending out messages about this pneumonia. There was a rush on antibiotics, vinegar. In stores, people use vinegar in traditional Chinese medicine. And it took about 10 days for the government to come out and make a statement about what was going on, that this was a new pneumonia, and this is where it was occurring. The next day, February 11th, is when the news went international. You could pick it up on ProMed Mail. The epidemic took off in Guangzhou. Several days later, the Ministry of Health went on television and said that we have the epidemic and it's coming under control, and people criticized him for that. But actually, if you look at the curve, the epidemic in Guangzhou did come under control. So we got there in the middle of March, when the epidemic in Guangzhou was coming under control. We didn't get into Guangzhou until the end of March or so. And one of the things was to find out what was going on. Was this the same pneumonia that was occurring in Toronto and Vietnam and other places at the same time? So we finally were able to go to to Guangzhou. And one of the first places that we visited was Hospital Number 8. It's a small infectious disease hospital in Guangzhou, 400 beds. And by the first week of February, they had 150 cases of this severe acute respiratory system. They were overwhelmed. The doctors and nurses were working 16, 18, 20 hours a day, barely keeping up with things. And things were really chaotic. There was transmission in the hospital, so other patients in the hospital were getting infected. The hospital staff was becoming infected. Visitors were becoming infected. They ran out of masks. At nighttime, if they had a few minutes to rest, they would sit around and sew masks to keep up with the masks. They ran out of ventilators, had to get them from other places in the city. And within a week or two, 20 doctors and nurses were hospitalized with SARS. So this was a terrifying situation to be in. And I think when I heard the story, it set chills up my back. I just couldn't imagine what it was like to be at that time. This is, again, a disease that you don't know what it is, you don't know how to treat it, and you don't know much about it. Conditions in the hospital were very rudimentary. They had to turn off the air conditioning because they didn't know how it was being transmitted. This was a ward of about 20 rooms. They had one sink, and so had to set up makeshift infection control. But they were able to bring the epidemic under control. And this is at a time also, there was no diagnostic test for SARS during the whole outbreak from the start to the finish. That came after it was all over. So all the diagnosis was a clinical diagnosis. And if you look at the percentage of people who were infected, healthcare workers were a huge part of this story. But they figured it out under the gun, and they developed expertise and guidelines for managing the infection in the hospital and taking care of patients, and then published this throughout China. And what exactly did they do? Well, a lot of the transmission was occurring in the hospital. And so the way SARS was transmitted typically was people would become sick, typically towards the beginning of the second week of illness. And the people who were real sick were the ones that were the heavy transmitter. So a lot of the transmission was occurring in healthcare facilities. And so strict infection control was crucial. And the people in the hospital number 8 realized that infection control as usual didn't work. It had to be very intense and very strict. And so the whole idea of eye protection really came out of this experience. That they figured out that's how a lot of people were getting infected. Ventilation. They didn't have negative flow rooms, since they had to figure out how to get the air supply working. Isolating patients. So the whole concept of not cohorting patients, you don't put two patients in the same room if one you think has SARS and one you're not sure. But they had to learn that on the spot. And then visitor policy. They ended up actually shutting down the hospital. No visitors could come in. So if you had a family member who was deathly ill, you couldn't get in to visit. And then they realized that they needed to concentrate the patients, the healthcare workers, and the resources in individual hospitals. So they came up with the concept of SARS hospitals, where the only patients in the hospital were people who met the definition. Fever clinics. Someone came to the hospital with a fever or a cough. You don't want them mixing in the emergency room, so you triage them outside of the hospital, make them a diagnosis or put them in isolation while you're coming to a diagnosis, but keeping them away from other patients. And then at the same time in the community, contacting traces, tracing contacts, finding people who are exposed, getting them in quarantine, isolating people who might be sick. So all these principles were worked out really in a matter of a week or two under intense pressure. And they did it. So the epidemic in Guangzhou, when we went there, our conclusion to WHO was, yes, they have brought the epidemic under control. There's very, very little new cases occurring. But at the same time, starting the end of February is when SARS went international, and it started with this person, A, who is a physician working in Guangzhou, went to a wedding in Hong Kong, stayed in the Metropole Hotel, and infected about a dozen people that then started the international epidemic. And so the outbreaks in Hong Kong, in Toronto, in Vietnam, and Singapore all started with this individual. He was a super spreader, a Sars super spreader. And so this is someone who, because of probably large amount of virus that's being shed into the environment, and then the opportunity to infect people. So someone who's contagious in the hospital could easily become a super spreader, infecting a large number of people. So this one person, accounting ultimately for hundreds of people, this was from the outbreak in Singapore. And the super spreader, I think, is something we want to keep in mind with the current epidemic, because there are super spreaders. Think of what happened locally at the convention. That was a super spreading event. And this is unpredictable, and this is where things can explode and get out of hand very, very quickly, unexpectedly. And I think this is part of what happened in Beijing. So Beijing had their first case in early March. They implemented the national guidelines in mid-March. They had surveillance in the hospitals, some in the community. They took 4 hospitals, cleaned them out, and made them dedicated SARS hospital with a capacity for about 500 patients. And by early April, they had reported 19 cases in the city of Beijing. But at that time, there were rumors of unreported cases. A lot was going on. The population was becoming restless and worried. So the Ministry of Health actually, at this point, were on pretty friendly terms, asked us, would we stay? We were getting ready to go home. Would we stay and look at the situation in Beijing? So we went into hospitals and clinics and visited the different health different health agencies. There was a lot in the news, and some of this you may remember back then, reports in Time magazine of how patients and situations were being concealed from us. And so there was a rumor of patients, 65 SARS patients in a military hospital that were concealed, and in the middle of the night they came in taxis and ambulances and took them away and hidden them. It was a senior surgeon who actually we spoke to on the phone. And so we said, well, we need to get into the military hospitals, and our colleagues in the Ministry of Health and the China CDC laughed at us. We can't get in the military. You're not going to go. So we did what WHO had us do. Was we had a press conference, and we said, this is what's going on. We hear about this. We need to get in. And then miraculously, we were allowed into the military hospitals. And we went to 2 military hospitals. 301 is where the outbreak supposedly had occurred and where the patients had been squirreled away. And what had happened? Well, we met with the Chinese physicians. They're all in their uniforms. They were very serious, and so we kind of said, why are we here? Why did we do this? But they were doctors in uniform. They were very happy to talk about the cases and everything. And what had happened was the first hospital where the cases occurred couldn't take care of them. They were having transmission to healthcare workers and visitors and other patients. And so they decided to move all the hospitals to the infectious disease hospital. And they did that in the middle of the night with ambulances and vehicles and whatnot. So it happened. So the question was, why weren't these reported? Why wasn't this part of Beijing's statistics? And they kind of laughed and said, well, what are you talking about? The military doesn't report to the civilian government. So the Ministry of Health didn't know about this, and this was just a function of the Chinese system. I think that's true of other military systems. I don't think it's unique to China. But also, I think that what this points out is the whole reporting, both civilian and military, was very complicated. And I think one of the things that slowed response down in China was just getting information up and down the chain. The system was not nimble. And this was one of the things that WHO wanted us to focus on, was encouraging China to improve the public health system. So we did our investigation in Beijing. We visited all the hospitals and clinics and whatnot, and then we reported to the Ministry of Health and the mayor of Beijing, and then we had our typical case, our press conference. And what we said was we thought, just based on what we had done, that there was at least 100 or 200 cases unreported in Beijing. And we suggested that there were problems with the case definition, surveillance, and reporting, and suggested that the government go into all healthcare facilities, use the WHO definition, and search for cases. And so that was our recommendation. But 2 days later, we're summoned back into the Ministry of Health office, and we thought, okay, now we're in trouble. We'd pointed the finger, and he said, my friends, you did your investigation, but I have to tell you, you were all wrong. It wasn't 100 cases, it wasn't 200, it was well over 700. And here's what we're gonna do. We're gonna have a press conference in a day or two, and we're gonna report what happened. And this press conference, 2 hours with English translation, was mind-boggling. The government came clean and said, we messed up, and there are all these cases out there, and this is what we're gonna do. And one of the things was we're going to turn the whole operation over to the central government. Madame Wu Yi, Vice Premier, who had just come into government, was in charge of the operation. And then our friends, the Ministry of Health and the Mayor of Beijing, were fired. At that point, we thought maybe this was a good time to get out of town, and we had been asked to go to Shanghai. It was very hard to get seats on plane. Everyone wanted to leave Beijing, and when we got on the plane, we were very high profile with the press, and so we talked the night before, said, should we wear masks or not? And we decided we're not going to wear masks because that would be sending a message, and maybe it's the wrong message. So here we are on the plane going to Shanghai. I'm holding my breath, and my friends on the team are laughing at me because if you look around, everybody else on the plane had a mask on. But the fact is, there's very little transmission on planes, but there was an exception. There was one flight from Hong Kong to Beijing, 120 people on the plane, 22 people acquired SARS from one person on the plane who was infected. 5 of them died. So you want to be a little careful on airplanes. Got back to Beijing. Beijing was kind of what we're seeing in Boston today. The streets are emptying out. So people were not out on the streets. People were afraid. And the few brave souls you'd see would, of course, have their mask on. And what had happened in Beijing was the epidemic exploded. And so they were getting 150, 200 new cases a day. And this is what we were afraid of, was persons with SARS who you couldn't find where it came from. You couldn't trace a contact. So they weren't happening in the hospitals or the clinics. They weren't in families, and they were cases in the community. This is where we are today. So community spread. And this changed really the whole idea of how to approach this from what was infection control intensively, case finding, and contact tracing quarantine was the strategy up that point. And this meant that this was failing. And we in the WHO group looked at this and said, this is what we had hoped to avoid. And at this point, we think that SARS is not going to be stopped. If it's not stopped in China, it's going to go global, and it's going to be a different ballgame. And trying to find out what exactly had happened in Beijing. So there weren't enough effective fever clinics. So people would come to the hospital sick, and they would infect the triage person. They would sit in the waiting room, infect other people in the waiting room. They'd get to the emergency room, infect other people, admitted to the hospital, and infect other people on the floors. So they didn't have enough fever clinics. They didn't have enough SARS beds to keep people separated. In the hospital, there was transmission. So they had healthcare workers with SARS in over 70 hospitals in Beijing. They ran out of supplies, and staffing became a real issue. And then in the community, the surveillance was not totally up to snuff. And the public was losing confidence in the government. And people who were sick didn't want to go to the hospital because if they didn't have SARS, they thought they would get it. And people actually in the hospital, some of them would escape and jump out the window to try and get away. So the epidemic at that point was out of control. And we were the quote-unquote expert team and kind of put our hands up. What's going to happen? We got to mitigate now, I think, because we didn't use the term back then, but I think that's what we were thinking. But the government had a different idea. And so the central government has taken over the whole SARS effort. And did some things back then that we're hearing about a lot now, so it doesn't sound as dramatic, but back then, the idea of canceling the May 1st holiday in China, I mean, that's equivalent to saying, okay, no Christmas and New Year this year, everybody stay home. Shutting down all the schools in Beijing and universities, all places where people gathered, so theaters, libraries, restaurants, and everything like that. Several hospitals with cases in transmission shut down, put on quarantine, no one in, no one out for 15 days. Identifying contacts, putting them in quarantine, enforcing reporting. So on the radio you'd hear, any healthcare worker who fails to report a SARS case will be seriously punished. Don't know what that meant, but people took that very, very seriously. And this huge educational effort to get the word out, to get people thinking about SARS. This is one of the hospitals shut down. They put yellow ribbons around it, no one in, no one out, 15 days. They left food on the windowsills for people to eat. They took 16 hospitals in Beijing and met, all of the hospitals in Beijing met one night, and they emptied the patients out of these hospitals and distributed to other hospitals, and these hospitals became SARS hospitals. The next day, the carpenters came in, remodeled the wards so that the flow of healthcare workers was such they wouldn't infect each other. This is a negative flow room. You open the windows and put a fan in it, and that was the strategy there. And we've heard about building hospitals in a short time. This was the 1,000-bed hospital built in a week. We visited it the night before it opened. They were putting windows and sinks in. I said, you've got hundreds of patients coming tomorrow. What are you going to do? We will get it done. If we don't, we won't get paid. They got it done. And it was an amazing hospital. It was designed beautifully for infection control to keep healthcare workers safe. Running out of supplies, and so getting factories that made toys to make masks and gowns and importing supplies from overseas. And so just sheer quantities of gloves and gowns and masks. Ambulances, they needed special ambulances so ambulance drivers wouldn't get infected. Ventilators, et cetera, et cetera. And then some very clever strategies. And we're seeing this in Boston now, but the fever clinics, don't put them inside because people get infected inside. Do your triage outdoors. So this was a fever clinic. You came in, you had fever, you sat in one of those chairs while you were being evaluated. Extremely rigorous infection control. So the medical students and public health students in Beijing were out of school, and they volunteered to work in the hospitals. And what they did, they would sit where healthcare workers would be putting on and taking off protective clothing or watching them work. And if somebody slipped up and did something wrong that put them at risk of contamination, they would stop them. Screening people throughout the city for fever and finding them, getting them in isolation, getting them evaluated. The healthcare workers were amazing. So the way it worked in the SARS hospital, you were on duty for a month. And during that month, you were in quarantine, which meant you didn't go home. You either stayed in the hospital or you went to one of the local universities to stay. Then you got 2 weeks off, but you were quarantined for those 2 weeks, and then you were back on. And working conditions were brutal. The standard infection control was several layers of gowns, masks, hats, gloves. It was sweltering hot. It's getting warmer, and nobody has air conditioning on. And then meanwhile, working with this very dangerous disease, your colleagues are getting infected and dying. The stress was unbelievable, but what was most remarkable was how talking to the healthcare workers everywhere we went was, how are you handling this? I am proud to do this. This is why I'm a doctor. This is why I'm a nurse. This is what I'm meant to do. It was just mind-boggling what we saw. We worried about transmission in the provinces where the infrastructure was not as strong. And so one of the things the government did was tell the floating population, the people from the rural areas working in the large cities, not to go home for the May holiday, trying to keep people put. But people did move. They didn't have the lockdown that they had today. But when somebody traveled and they came into a province, they were stopped, examined, registered, and then kept track on. And if they had come from an endemic area, like Beijing or Guangzhou, they were put in quarantine. They had intense surveillance in the community and massive health education. So this was, we went to the province, we would be stopped, we'd have to get out of our vehicle, get our temperatures taken 10, 12 times a day. We'd have our temperature taken. Every time it was taken, you had to fill out a form and get registered where you're going. Do you have any symptoms? This was the Ministry of Quarantine, one of the top government officials. She had to get her temperature taken as well. Hunan province, they registered 1.4 million people coming back into the province in a 3-week period of time. 800,000 of them were put in quarantine at home. So this poor guy got back, and his wife wouldn't let him in, so he had to spend 14 days in the chicken shed at home. They picked up 12,000 people with fever and some with cough. The yield ultimately was 9 confirmed cases of SARS. But the whole idea here was if you had a super spreader and that person got through, you had another epidemic. So they were trying to catch everyone. At the village level, they had several different authorities responsible for every single person. Temperature daily, staying put, movements, et cetera, et cetera. If someone was on quarantine, they would deliver food, they would help with the work in the fields. A huge education effort, and then participation of the community. So this is a village. There was a case of SARS in this village. The village was locked down, nobody in, nobody out. We were able to get in. A ghost town, nobody out, and you'd knock on the door, is anybody home, and you'd hear voices, but they wouldn't come out, and they were being monitored daily by several different groups of people. This was an isolation station. They ran out of hospital beds, clinic beds. They used schools. They used other meeting places. They took over clusters of houses to put people in isolation while they were ruling out whether or not they had SARS. And then the education was phenomenal. Everything was SARS. Everywhere you looked, the radio, the television was SARS, SARS, SARS. And everybody knew what to do. And so you'd ask children on the street, what would you do if your little friend was sick? I would take her to the fever hospital, or a taxi driver, somebody's in your taxi and he's coughing, where would you take him? Not where he wants to go, I would take him to the fever clinic. And if he didn't want to go, I would take him to the police station. And so the way it worked was if you had SARS, there was almost nowhere to hide. I mean, they had you. And if you could hide, you weren't going to infect anybody, because otherwise you'd have to see someone else. So China made this thing happen. They stopped this literally in weeks once the government came in. But it was this massive effort, kind of what we saw in Wuhan. And so the idea here was containment and stopping it. So it was getting every single last case. We're talking now about mitigating, which is to slow down the epidemic to kind of, they talk about flattening the curve so we don't get these high peaks, but we get a more sustained lower level. But one of the questions, we're still counting cases, and WHO has not endorsed full mitigation for countries. It's still saying we still should think about containment. And I think that's something we may want to talk about, is where are we right at this moment in the current epidemic, and what can we learn from the Chinese experience? So here China is removed from the list. A lot was learned in China, by China, and by the world. And so having a strong health care and public health infrastructure, I think, is key. And I think when we look at the current outbreak here, I think we're seeing some weaknesses in our own system that I think coming out of this, can we strengthen things? The importance of communication and transparency. If you've got an epidemic, you've got to come out and talk with the population, and I think we can do better with that as well. And then the old-fashioned strategies for control: case identification, containment, isolation, quarantine, as well as social distancing are so critical. The media plays a big role. The international community came together, and we've seen that with this outbreak as well. Scientific achievements, they identified the organism, the virus. The Chinese actually had done it in advance of the people in Hong Kong and Canada who got credit for it. They weren't allowed to publish it. And then some changes in international health law. So that's what I wanted to talk about, what we saw in China. It was amazing. And when I think of things I've seen in medicine that have startled me, this is right at the top of the list, along with antiretroviral therapy for HIV and whatnot. This was remarkable. And I think what we're seeing in Wuhan also is amazing. I think China is going to contain this epidemic, which is again, mind-boggling. But look what they're having to do. Look what it takes. They've got the government to do it. They've got the population that can comply with what the government is asking them to do. Things we can't do, but I think there are things that they have done that we can do. So I think we have to learn a lot from them, and hopefully we will learn. People talk about what's going on in South Korea and Singapore and Taiwan, how they're doing very well. They all had outbreaks of SARS. China had an outbreak of SARS. We only had 9 cases in the United States, so we didn't learn our lesson the hard way, but I think we can still learn from the experience of others. So that's what I wanted to say. Thank you very much, and Deb?
Thank you, Jamie. That was amazing. It's astounding what happened at that time. Why don't we have a seat and talk a little bit, and then really open it up to questions to people who are listening online.
Good.
So let's start with, as you say, containment versus mitigation. Where are we? What are we doing? Are we investing in the right efforts right now?
Yeah. It's probably hard to tell for sure because we're not clear exactly where we are at the moment. I think we're handicapped by that, but we're still counting cases. And I think at some point, if we go into mitigation, which means that we're really going to hold back on contact tracing and finding people who are in contact, getting them in quarantine and whatnot, and work on social distancing and mitigation. At some point, we may get to the point where containment again becomes an issue. Are we going to try and really get rid of this thing altogether? But I think that there's a role for containment still, and it goes back to the super spreaders. And so, you get one of these red hot cases in the wrong place at the wrong time, you could have a catastrophic outbreak. And so I think there's really a role for both of those. I know we're heading towards mitigation, but I don't know if that's the right strategy. WHO is still arguing to not drop containment.
And then kind of as a follow-up to that is the idea of interruption now a hopeless pipe dream?
That's a good question. I think we had a chance. I think when China decided to go after their outbreak in this incredible fashion that they're doing, I think China is going to contain it and stop it. And I think we had a breathing spell for the rest of the world to get ready to be prepared and to stop it. I think we've gone. So it's really up to the rest of the world right now. And I think the way it's spreading and the number of countries that I think we're probably not going to interrupt is my guess.
Let me ask one more question, and then we'll open it up to other folks. But as we all know, the Chinese government is very unique and different than many around the world. What do you think is possible, right, when you have governments that are kind of more in the structure that we have here?
Yeah, no, I think that's a great question. I think what China did during SARS, probably no other country could do. What China did in Wuhan, I don't think any other country could do. But I think what we're seeing is Italy is under lockdown, and that's amazing to me. And I think when we look around Boston today, and the streets are emptying out, people are afraid. And so I think the population is going to do some of the things that the government's asking us to do or suggesting that we do voluntarily. And so whereas in China, I think you have more authority and a population that is very socially minded. But I think we've got factors here too that I think are going to hopefully be effective.
So I could talk all day with just my own questions, but I'll try to refrain and let folks who are sending in their questions pipe up. So, Roby, Sharon, do you guys want to?
So, I can start with a question coming in from B. Haas. Is it true that common surgical masks are not effective at preventing contamination? That's the message we're giving for healthy people in this country. And if so, why do we see so many folks in your pictures and in other places outside the U.S. wearing them?
Yeah. Surgical masks are effective for droplet spread. And so a droplet spread, if somebody coughs or sneezes and expels some droplets within a range of 3 to 6 feet from the person who's exposed. The most effective use of the mask is on the person who's coughing or sneezing. If you're close to such a person who's ill, yes, a surgical mask is helpful. I think beyond that, wearing them in public really doesn't help very much, and probably gives people a false sense of security. They may do things that they wouldn't do otherwise if they didn't have a mask. And you have to be careful with masks too. Masks can get contaminated, and you can contaminate yourself from a contaminated mask. Deb, I don't know, you want to?
No, completely agreed. That's the message we've been trying to send. So I appreciate your reiterating that message.
Christian asks, many schools are now closed and parents are home with kids wondering how strictly to keep them away from other kids, neighbors, with no real guidance from the schools or CDC yet. How should parents think about this?
Well, I think one thing about closing schools is a partial mitigating measure. And this is where I think really having a broader strategy is going to be important. I mean, if we close the school, what else should we be doing? Because that's just a small part and probably not a major part of the problem in terms of the transmission chain. And so if we're going to close the schools, I think we really need to think about closing down a lot of other things as well. So that's a little bit about the overall picture. But with the kids at home, it's going to be tough. It's getting warmer, and playing outside is safer than playing inside. So I think that's going to be an important intervention. Children are not becoming infected at the rates that adults are, and we don't totally understand why that's so. We also know that if children are infected, the outcome is not as severe as with adults, so that's reassuring. So I think get the kids, let them play outside would be one of the messages.
Jamie, so how important do you think that was, closing the schools back in 2003? And do you feel like it was just part of a bigger overall plan, and to do it in isolation, it's not clear how important that is? Yes. What are your thoughts on that?
Well, I think it was part of a bigger plan. And so I think the bigger plan was on a large scale social distancing. And so the places where you have a lot of people coming together, schools are obvious, but they had any other large meeting place was banned. And the whole idea, the message that came across was get out of contact, get out of circulation. So the streets were empty. So I think it was not a separate, unique intervention.
But tell us this, right? Because you kind of watched that part in real time, right? Everyone here has never seen that before, and so they're trying to kind of wrap their minds around how to even frame and think about this. So, for example, let's just, not to fixate, but let's just use the example of closing of schools. What was the thought process then? How long did they end up closing? Did they decide right from the outset, oh, this is the time period? Should we even be thinking in terms of discrete time periods, or should we be really leaving it open-ended and saying until further notice?
Yeah. So first of all, this was on the fly. That the initial strategy was.
We're on the fly now too.
And we are on the fly, exactly. The initial strategy was containment and case identification, hospital infection control, and then all of a sudden that wasn't working, and so this was this massive intervention put in all at once. And so I don't think there was a time limit on it. I think the time limit was when things get better, we will stop. And so I think one of the things was what did this mean for the Chinese people, and what does it mean for Chinese people now, hearing about friends in China, what they're going through? It's tremendous sacrifice and stress and this is a rough, this is a very, very rough time, and not having an endpoint, I think, made it even rougher. But I think people were frightened, and that, I think, helped people to put up with it, and I think having the reports of what was happening to the numbers, I think, was reassuring. I think that helped people get through that tough time.
There's several questions about super spreaders. So what is known about them? Can they be predicted in advance or only determined in retrospect? Do you think it's related to viral factors, patient factors, environmental factors, just the fact that someone infected happens to go to a large event?
Yeah, I think that's a great question. I think back in SARS, super spreaders were typically people who were very sick and had we think, a large viral load. And then they had the opportunity to infect large numbers of people. So it was both the biological situation and the social situation that they had. I think in the current outbreak, it's different because I think people who are highly contagious are highly contagious as a much earlier time when they're not real sick, so you can't identify them as easily. And why is someone a super spreader and someone not? Does it have to do with viral load? Does it have to do where the infection is taking place? Is it more in the nose than further down in the respiratory tree? Is it something about their air passages? Is it their immune system? I think these are all excellent questions, and I don't think we have answers. Deb, have you?
No, but I am actually almost hearing from you, Jamie, that you think that's actually one of the critical or high priority questions that we should try to understand. Because I'm hearing from the experience in SARS in China, it's actually the super spreaders that are almost the biggest problem that needs to be contained. Right? That there will be ongoing low-level transmission, infections, but it's actually capturing the super spreaders if we could figure out how to identify them.
Absolutely.
Would almost be one of the critical steps in trying to manage the outbreak.
And if we could identify them, and I think we can. And so then the solution in China was to put out this net that caught everybody. And so there's one super spreader out of thousands of people. If that person gets through, you've got a problem, and you want to contain them all. But I think it may continue to be a problem with this outbreak, particularly as things slow down, and then we get recrudescences of local spread.
What are the Boston-based hospitals doing to prepare for the influx of patients that may be coming in the coming weeks?
Yeah. So I can't speak for all the Boston hospital. I know what we're doing in our hospital, but I think it's a good question because I think we need to think ahead about worst case scenarios. And so what happens in Boston if we end up with an outbreak like Beijing or like getting close to Wuhan? We could be overwhelmed very, very, very quickly. And the whole idea of the specialized coronavirus hospital, I think, is something that we really need to think about. We want to keep patients separated. We want to develop expertise. We want to keep the healthcare workers safe. So I really think that we need some advanced thinking about what will we do if we're overloaded. In our hospital, we have a number of beds that are set aside for patients with coronavirus, and we've got teams who are ready to take care of them, and infection control materials and training and whatnot. But a rapid influx of a large number of patients could overwhelm that very, very quickly. And so I think that's a great question, and I think it's a word that we need to think about.
That's really interesting. We're not in a position to build a 700-bed hospital in a week. Right.
Yeah.
So that would require a lot of coordination among the existing health systems.
Yeah. And I know people have looked at the use of intensive care facilities in the Wuhan outbreak, and that if we followed the same pattern in terms of percentage of people that's infected, percent of people who are critically ill, we would overwhelm the country's capacity to take care of these patients. And so I think we really need to think. They're talking about rationing materials in Italy. They don't have enough respirators and whatnot. So we really need to think ahead and think the worst. I think part of the problem is, you look around, we don't see much, we don't hear much. It's out there, we know it's coming, but it's not here yet. And again, the countries that are doing well with this went through it before, and I think in a way we're reinventing the wheel. We're going to learn it the hard way, unfortunately.
Yeah. I will say, as you know, that there have been conversations between our community, right, and the hospital systems and doctors in Wuhan and Guangzhou and other places. But it sounds like it's certainly not to the level that we should be having. And incorporating that more aggressively into our thinking and management.
There's a tremendous amount of expertise in China that pulled off what was pulled off during SARS, and amazingly now in Wuhan. And again, they have the government, they have the resources, they have the ability to do things that I think we can't do. But boy, as this thing was unfolding, they had the right moves in a very short period of time. I think just like in SARS, the early stage, there were some mistakes, and I think that the whole question of person-to-person transmission, there were a couple of weeks in which it was clear that was going on, but it wasn't recognized, it wasn't reported, and I think that was a loss of time. But once it became clear, I think the courage to pull the trigger, put Wuhan, the whole city, under lockdown is mind-boggling. But that's what it's taking to do it.
And that's probably because of their experience with SARS.
Exactly, yeah. So I really think there's a lot to learn, and I think our Chinese colleagues would be delighted to help us. Dr. Zhang in Guangzhou, who we met and worked with during the outbreak, is an amazing guy, and he was really a hero during SARS, because when people were thinking it was a chlamydia, he was saying no. He knew about the infection control. He came up with some of the procedures for managing patients, and so he's got a huge amount of expertise. He and others like him.
So there's been several questions about diagnostics, and I will try to summarize into a couple. What effect do you think the delayed diagnostics in the U.S. has had on spread in this country, and what does that, do you take any lessons from that in terms of what we can do going forward for new diagnostics in an epidemic setting versus regulatory constraints around other diagnostics? And part two, what do you see the role of diagnostics now if we're switching to mitigation phase? Yeah.
All excellent questions, and Deb, you can help me out with this. There's been a lot of discussion about that. I mean, I think we lost a lot of time in this country not having diagnostics up to speed. So I think we would have a much better appreciation of the extent of the epidemic, and perhaps our preparedness would be more advanced had we had that information. I think infection was out there, we didn't know about it, and I think that slowed our reaction time down. The state of the art in terms of development of testing is amazing. I mean, they identified the virus, had it sequenced, and had tests in a very short period of time. And we have that capacity. And I think regulations need to be more nimble and flexible to allow other sectors to come up with these diagnostic tests. I mean, I think that was a missed opportunity. I think it's still going to be important to have a diagnostic test because in terms of mitigation, one of the centers is going to be the healthcare units, and who gets into a facility, who's admitted. We want to keep our healthcare workers safe, and so just from the clinical part, that's going to be extremely important. And then I think just to know where we stand in the epidemic, we need the data.
Another diagnostic-related question or two. Why can't we perform testing at the rate of South Korea? How are they able to do it and we can't? Wouldn't a simple PCR test be sufficient? I understand the need to validate, et cetera, but the risk of having some false positives and false negatives seem minor compared to having lots of potentially mild cases out infecting others.
Yeah, I think we can do it too. We could do it. We could have done it. And I think again, it was the regulation and the requirements that slowed us down. And then this unfortunate mishap with the testing kits from CDC that had a flaw. But I think there's no reason we could not
So the whole SARS outbreak was managed without diagnostics.
Without diagnostics, yeah.
Now, to be fair, right, as you pointed out, that those folks were symptomatic, right, which probably allowed the public health tracing to be a little bit easier. But can this be managed without diagnostics?
Yeah, so certainly SARS was much easier. I mean, not only was it that people were sicker, but also when you heard the case history of someone with SARS, it was very different from other respiratory illnesses and flu. You heard the story and you could say, that's SARS. They had a week of a certain kind of symptoms, and then they progressed in a certain way, which was kind of the reverse of what we see with a lot of other pneumonias. So you could, and it was interesting when they finally had serological tests and retrospectively went back and tested people who were diagnosed clinically. The clinical diagnosis actually was fairly robust, which was impressive. This one is very different, and so I think that if we're stuck with a clinical diagnosis, I think it's really almost a public health kind of tool, that if you've got respiratory symptoms and we can't tell whether it's a cold or the flu or coronavirus, you're out of circulation and you stay put until you're sick enough to have to come to the hospital. I think it's going to be a different element in the social distancing, including distancing of people who are mildly sick.
While this was going on, let me rephrase it. One of our biggest challenges right now is trying to balance educating people that this is a serious business without wanting to cause panic. How did they manage that in China in 2003?
Yeah, well, I think what they learned was if you don't speak up and you don't educate, people will panic. And so I think one of the worst mistakes is not being honest with people. And I think if things are going to get worse, you really need to tell people that it's going to get worse, because if they get worse and you haven't told them, then loss of confidence in the government, in the system, and things are going to be a whole lot worse. And so I think you need to be truthful. You need to be open, and I think that should be right at the top of the list of priorities. And then I think right now, for instance, we're telling people this is coming and we're trying to mitigate, and it's going to be, you're going to have to make some sacrifices. You're going to be at home, you're not going to be able to go out, you're going to take a financial hit, but we're all in this and we've got to do it. And if we don't do it, it's going to be a lot worse. And just, I think, get that message out, try to get people to understand that. And I think a little fear is okay, because I think it's keeping people off the streets.
Yeah. So you're saying that the way, rather than being afraid of the panic that might ensue from being honest and telling them how this is a serious thing, that panic is less than the panic that happens when people feel like we're not being honest and we're not keeping them informed.
Yeah, and
is
things
that right?
And things, and especially as things go out of control, and then I think there's real panic. Yeah.
So we're running against time. There's a lot of good questions, and I think this is going to have to be the last one. But with the world so much more interconnected than it was with the first SARS outbreak, at what scale do you think interventions, even for mitigation, have to happen in order to be effective? Local, regional, state, national, or even global?
That's a very good question.
And who's in a position to implement that?
So I think, again, I'm not sure how this is all going to work out. I think that the unit that is going to be the focus, I think, is going to be on countries and how each country is able to handle its own issue, because countries are different and you're going to have different levels of infection and whatnot. But at some point, it is global. And I think this is where, again, World Health, I think, has got its eye on the ball and is still hoping for containment and looking at the big picture, the end game type of thing. I mean, one thing we haven't talked about are other tools that weren't available during SARS that hopefully will be, like a vaccine. hopefully will be a game changer in all of this. And I think that will be an international effort and an international rollout. And hopefully, if there is a happy solution to this, this will be a big part of it. But I think right at the moment, it's local and individual countries. And China right now, I mean, one of the interesting things in China right now that I'm hearing is that they are having issues with imported cases. And so they've actually simmered things down enough, and now it's people coming into the country and slipping through the cracks that are their big focus.
So because of time, I think we have to stop. Unfortunately, there are not enough here to give you the standing ovation that I would like. But to just really thank you for the insight you're providing. Thank you for the service that you provided back in 2003. And thank you for the continuing work you're going to be doing. I know that because you and I go on service for infectious diseases at the Brigham next week together. But really, we greatly appreciate your taking the time out to teach us. Yeah. I think that's, we don't want to recreate the wheel. And so any lessons that you have learned that you can share and continue to share, we greatly appreciate it.
That's very, very kind of you, Deb. Thank you for the opportunity to be here, and good luck to everyone.
Yeah. And let me add just to the crowd to know that there's actually a small group of us who are trying to strategize to see if we can have a few more of these talks to give different perspectives on the pandemic. So stay tuned. Thank you.